Hey guys, good evening. I'm super fortunate to have been able to gather this panel. Um, when I was tasked with trying to figure out how we could have a COVID conversation, I wanted to make sure I leaned heavily on the experts. And so I'm super happy that all you guys took the time to chat with us. Take a moment and introduce everybody. So we have Dr. Gerald Onuwaha, who's a practicing internal medicine hospitalist in Tennessee. He received his medical degree from Meharry Medical College as well as a Master's of Science from Dartmouth. While at Meharry, Dr. Onuwaha received a litany of awards and started a project, Dream Community Initiative, which strives to promote disadvantaged students to pursue a career in healthcare. Most recently, he's been active fighting for social justice and educating the community about COVID-19. So welcome, thank you. Dr. Purvi Parekh is an adult and pediatric allergist and immunologist in New York. She completed her residency at Cleveland Clinic and fellowship at Yeshiva University. Dr. Parekh is a medical contributor for CBS News, CNN, CNBC, NBC, Fox News, and US News, just to name a few, and was recently featured in In Shape magazine. Welcome. Dr. Cedric Rutland is a pulmonary and critical care physician in Southern California. He's a national spokesperson for the American Lung Association, assistant clinical professor of internal medicine at UC Riverside, as well as CEO and medical director of the Rutland Medical Group. Dr. Rutland has mastered the ability to deconstruct medicine and make it palatable for the public. So thanks for joining us. And then we have Dr. Benjamin Thomas, who's an emergency medicine physician practicing in California as well. He completed his residency with the Alameda Health System and now serves as the clerkship director for emergency medicine at his hospital in Northern California. Dr. Thomas has a passion for medical education, mentorship, as well as diversity, equity, and inclusion. He recently wrote an op-ed for the New York Times entitled, "How to Reassure Black Americans That the Vaccine is Safe." So we'll put your theories to the test tonight, Dr. Thomas.
Awesome. And they all, again, there's 7 types of coronaviruses, right? So 3 of them are severe. The other 4 are coronaviruses that cause the common cold in adults and children and have been doing that for years, right? And they all have names. There's SARS-CoV-1, MERS-CoV, SARS-CoV-2, then there's HKU1, 229E, NL63 and OC43. They're all just names of coronaviruses. And so they're all structured in the same way, right? They all have a spike protein. They have 4 structural proteins: spike, membranous, nucleocapsid, and envelope. And then there's 16 non-structural proteins that are coded within their 8 RNA segments, in addition to other open reading frames and things. But I think it's important for people to understand that as a result of that SARS-CoV-1 pandemic in 2002, 2003, we were able to get like a 17, 18-year head start on what SARS-CoV-2 actually looked like, which allowed us to be able to accelerate through producing the vaccines that have been produced up to this point.
Yeah, I think that's a great point because, often people say this is a new vaccine or it was rushed, but actually we're building on knowledge that's been there for decades. So I just want to make that point because I think people don't realize that there's a lot of history even leading up to these vaccines itself.
We've heard a lot about differences in death rates. Is there something particular about the virus that affects people of color more than other communities, or what would you attribute that to?
No, this has been studied. COVID affects everyone equally. There's nothing innate in a Black person versus someone of Hispanic or Latin descent versus someone of Asian descent versus someone of white descent that makes them have unique or innate features that makes them more susceptible to COVID. What we do know that there's a disproportionate effect amongst people who are essential workers, who live in a multi-generational home, who don't have the luxury of being able to work from home, and who are essentially on the front line. And disproportionately, that means Black and brown communities who have to go to work on a daily basis, who may take public transportation, basically who put themselves at risk, at a higher chance of developing, becoming infected by the virus. So there's nothing innate to us as people of color that makes us more likely or more susceptible to COVID. We just happen to find so many of us in situations where being in highly populated areas, we are just more prone to getting infected.
You know, what he's speaking to really is he's speaking to viral load. So the more people are exposed, the more virus they're going to be exposed to and inhale. And we already know that the more virus that you're exposed to, the more likely you're going to develop severe COVID-19. And so when you look at our population, that is the Black and brown population, like he just said, we're going to work, we're exposing ourselves, and we continue to expose ourselves, which likely increases the risk of severity of the COVID-19 that we develop. So it has nothing to do with being Black, white, Asian, Mexican, whatever it is, and of descent that you are. It has everything to do with the amount of virus you're likely exposed to.
Right. That being said, though, I think the amount of the disparity is still there. It's almost 3 times as much. So yes, inherently, right, we're all the same, but it's still very disproportionate, like 3 times as much likely to have complications, to die from this virus. So, and I think it's like multifactorial because those disparities existed, right, long before COVID-19. So a lot of the high risk conditions, unfortunately, are also disproportionately higher. So it's almost like adding more fuel to the fire. So, you know, you could argue that certain preventative measures are even more important, right, for Black and brown communities.
Right. What kind of long-lasting effects of COVID-19 infection have you guys been encountering, or what's most pronounced that you've seen?
So I've seen a few things. Most people that get COVID-19 and have some type of what we call sequelae to it, a lot of that is chronic lung disease. I've seen a couple of recurrent pneumonias, some cardiac illnesses also. And we're paying attention to kidney failure. And that's what's going on here in Tennessee. And I don't know what else everyone else has been seeing, but that's what I've been seeing so far.
Yeah, I mean, everybody's so focused on the death rate. And I think a lot of the COVID naysayers, right, use that death rate to minimize it. But what people don't understand or maybe don't realize is that even if you survive, you're nowhere near normal. Your quality of life for some people has changed forever. So, you know, the perfect examples you had mentioned, irreversible heart damage, lung damage, people who never had any problems with their kidneys are now on dialysis.
Yeah.
And that's not even putting a light on all of these other surprises that keep popping up amongst the COVID long haulers, the people with severe neurological issues, their memory loss, they can't concentrate even on very simple things like watching the TV and things.
That foggy brain syndrome that we're seeing. Another thing that I'm seeing too is COVID-19 thickens the blood. And so we're getting a lot more cases of blood clots, especially in the lungs. And so that's affecting people that have gotten COVID-19 also. And that's very serious for us.
When you look at the sequelae of COVID-19, right? And again, I'm an outpatient pulmonologist as well as an inpatient ICU doc and pulmonologist. And I see these patients from beginning to end to chronically, right? And so what you're seeing is you're seeing an activation of the inflammatory response that doesn't stop. Now, the way that your immune system is constructed, right? You have many different white blood cells that all have a particular job to do. And as they're doing their job, they really want to do their job and leave. But what happens with COVID-19 is the white blood cells tend to stick around. They stick around in your lung, right? And so I'll see ground glass opacities. And what Gerald is referring to as recurrent pneumonias are actually a conglomeration of white blood cells in an area that they need to leave, but they're just not. And so you'll start to get this transition from epithelium, which is kind of like normal cells, to mesenchymal, which means they're more like fibroblasts and they start to scar. I've had multiple patients now that need a lung transplant as a result of the heavy activation of their inflammatory response. This inflammatory response continues to take place where the virus likes to bind. So it likes to bind on the blood cells, on the endothelium. It also likes to bind in the small intestine. And as it binds on the endothelium, it can also affect the brain. And so you have these conditions that all the doctors on this panel are describing that are a direct result from the presence of SARS-CoV-2. Now, going a step further, when you look at the patients that have severe COVID-19, 50% of them have autoantibodies, IgG autoantibodies
Mhm.
that activate this inflammatory response. And so this is something that we're going to continue to see that primary care physicians need to know about, including hospitalists, OB-GYNs, every type of physician needs to understand this because in all likelihood, they're going to see it. And they have to know who to refer to or how to recognize it and how to take care of it because it's an issue. And I've had to give people multiple immunomodulating medicines after their initial infection to be able to deal with some of these sequelae and some of these consequences. And that's why vaccination is so important, because not only are you preventing infection, but you're also preventing the long-term consequences of COVID-19. And that's what I think people need to come to understand. Like Purvi said earlier, yes, people aren't dying and it's only 2.5% of the population that's dying, but no one, and I'm going to repeat this, no one on Clubhouse is talking about the consequences of this virus, the consequences that people have to live with.
I'm more afraid of the virus. I mean,
For
to me,
sure.
it's a no-brainer. I know people personally who've passed away who are dealing with these long-term complications. So that's far scarier to me. I'll take my chances on the vaccine any day.
That's a perfect kind of segue. Let's chat about the vaccine kind of basics, if you could, Dr. Perrick. Tell me about the vaccine, like what's in it and why is it there and what the role of the vaccine is.
Right. So, I mean, the two that currently have emergency use approval in the US are both very similar in technology. They're mRNA or messenger RNA vaccines. So that's both Pfizer as well as Moderna. They're both 2 doses that are approximately 3 to 4 weeks apart. And it's really interesting. So the technology, even though it's the first time it's really been used in a vaccine, it's actually been studied and in studies since the 1990s. So by no means is it new or experimental or novel. It's actually been around quite a long time. And to be honest, I actually think this is going to be the vaccine of the future because it's really interesting how it works. It basically sends like a recipe to your immune system or a cheat code if you're into video games, or the best I've heard is Snapchat message. I'm not on Snapchat, but
That's a good one. That's a good one.
I like that analogy because just like a Snapchat message, it's there and then it's gone. And the reason why that fact is also important is because I've heard all these conspiracies that it incorporates into your DNA, there's going to be long-term harm, but actually the half-life or how long it lasts in your body is very short. The actual mRNA breaks down, half of it's gone in a week and then the rest the week after. But what it does is it actually tricks your own immune system into mounting immunity by producing that spike, from the coronavirus. And that spike is really what's responsible for the infections. It's responsible for you mounting immunity, but it does this without actually making you sick. So you get to have all of kind of the immunity and the benefits of that without actually becoming ill. So there's no virus at all in these vaccines, not dead, not alive. So I think it's great because with this type of technology, you can actually make vaccines very quickly and you can modify them very quickly. Because when you're using a real virus, like we do with other vaccines, whether it's dead or alive, it takes a long time because you have to engineer the virus so it's safe to inject into humans, So, I think it's exciting. Even some of the other vaccine candidates that are on the horizon, they're a little bit different technology, but, I think this is great in a pandemic where we're losing 4,000 lives a day. We really have no other good defenses against it.
So what does it mean to have immunity from this vaccine? Does that mean that, I don't have to mask, I don't need a social distance? Does it mean I'm in the clear? Kind of clarify that for us.
Keep masking, keep distancing. A vaccine's not meant to be a cure, right? What it's meant to do is meant to save your life if you do happen to get ill. It's meant to prevent you from ending up in a hospital and on a ventilator and having those dire complications that we had mentioned before. It's not meant to completely stop disease. It's not meant to completely stop transmission, but it's supposed to make it so that those disease rates, those transmission rates, infectivity rates are low enough that, we're not seeing devastating loss on a daily basis, so that we can move somewhat towards a normal semblance of living, But that being said, initially, until we have enough people vaccinated, and top experts are estimating that 75 to 85% of the general population, we still need to do those mitigation measures, masking, distancing, washing hands, because without that, not only are we still potentially spreading it, although the data is coming out as we speak, we also are increasing the chances of those strains and those mutations that we've been hearing about as well. So yeah, that was the long version to know, keep masking.